of the patients had an A1C of less than 9. 2% of the patients had an A1C less than 8. 88% of the patients were actually very well controlled for blood pressure control. And 63% of the population had an LDL less than 100. So this is back in 2012 when LDL was still a P4P measure. And now we'll show you what happened afterwards. And so this is just the first year. So now we have 82% of the patients with an A1C that's less than 9, 63% of the patients with an A1C that's less than 8. Modest improvement in hypertension control and LDL control. And so we actually surpassed our goal by 100%. So we said we were going to get 30% of the patients to goal, and we got 63% of the patients to an A1C of less than 8. And when you add on, when you compare to the IHA 90th percentile, you can see that in almost every measure we met or exceeded the IHA 90th percentile. And that's saying a lot because this is only an uncontrolled population compared to a population across the state of California that's both well controlled and poorly controlled. Now the question was, could we reproduce this? Was this like a one-time thing because we put so much time, energy, and effort and resources into managing these patients? And the answer is no, it wasn't a one-time thing. We've been able to reproduce those results year over year. So here we're looking at years 2015 through 2018, over to, it's kind of the maroon bar, is 2018. So you can see, we've exceeded the IHA 90th percentile with A1C less than 8 and A1C less than 9, as well as blood pressure control. We still have a little bit of work to do on the nephropathy screening. So that's why we're here today. Hattie's hoping that you might be interested to learn more about the program and hopefully maybe start something like that on your own. So I'm going to now turn it over to the person that actually runs the program, and she's going to talk to you a little bit about how the program's set up and how it functions today. And then I'll be back to wrap this up.
Thank you, Andrea. Everyone can hear me okay? All right, good afternoon. So as you heard in the introductions, I'm Kristi March. I'm the manager of our active diabetes program. And I'm also one of the pharmacists that helps provide direct patient care in the clinic as well. So today I'm going to be talking about and sharing with you our clinic operations, the treatment that we provide to our patients, and then also talk about the individual roles of the providers on our multidisciplinary team. So currently, our PCPs are the drivers of the referrals into our clinic. And that's really the best way to do it, we've found. The provider will, or the PCP will see the patient in clinic, talk to them like, okay, your sugar control needs help. I want you to go to this program we have. And it really helps with patient buy-in. We didn't start off that way, but that's okay. So I'll tell you how we started off. We had our data, we had our list of our patients, and we knew we wanted to start a pilot. We needed to show how we were going to make this happen and kind of get the PCP buy-in to get to the referrals. So we had our list of patients, and we got the blessing from a small provider group. That was one of the physician champions that Andrea had mentioned, agreed to let us call their patients on their behalf. So I don't know if any of you have tried to cold call patients before and get them excited about a diabetes program where we're going to teach you diet and we're going to help you manage your diabetes. It was really difficult to get them to come in. So out of about 50 patients that we called, and I personally called many of them, I was able to get 15 to come in for our pilot. So we had those 15 patients and we monitored them for about 3 months, and we were able to show really good outcomes by just really intense monitoring with our team. So that's how we started, and we were able to present those results after 3 to 4 months, and that's how we got the PCP buy-in and transitioned to provider referrals into the clinic. As you had heard as well, we had a lot of diabetes patients. So how are we going to narrow this focus? So you heard about how we decided to focus on the more complicated patients, the patients that were just frustrations for the PCPs and endocrinologists, because for some reason, they just couldn't be adherent to the recommendations. So we focused on that population, and over time, as our program grew in size and reputation, we were able to add another dietitian to our team, and we were able to respond to the request we had from the organization and from our PCPs to add in that preventive part for the newly diagnosed diabetes patients who may have a lower A1C, but of course we don't want them to get worse. And same with prediabetes and just patients that maybe have a lower A1C, but we want to make sure that they're not going to progress into worsening diabetes. Our patients are adults, mostly type 2. We do see type 1, but it's mostly type 2 diabetes patients who maybe have had some education, they looked up information on the internet, they get a lot of their information from family and friends. They really need help with tools for management. And that's really what we're trying to teach and do in our program. So over the years, we've been fortunate to try out different types of multidisciplinary teams. And what we found today is that the pharmacist, the dietitian, and the social worker is kind of that sweet spot for your team. At least for us, that's what has been working the best. The benefit of having a multidisciplinary team with our providers that we have now is it really allows us to provide that intense support beyond the usual care for our patients. So we meet with them on a one-to-one basis. A lot of times we're asked, well, what about group classes? So group classes are great. We had that option before we started our program, but I think one of the issues with this particular population is that they're in a class and maybe you have like a 45-year-old a patient that's still working and your 75-year-old retired patient, and you're presenting a one-size-fits-all diabetes class. And that just doesn't work so well for them to absorb that information and be able to take it back and really change their lifestyle to work with what that information is. I think it's good for overall general education, but in terms of actually making a change, I think for a certain population, it's really hard to expect that to happen with a class. So again, we find that meeting with them one-on-one, discussing what their areas of challenge are, finding areas of opportunity, and working with them to develop a plan that's going to work based on their lifestyle, based on their finances, based on their social background. So that's really the point of what we're trying to do with the one-to-one management. The care we provide our patients, it helps them engage in better sugar control and health outcomes, and at the same time we're lowering their A1C, which of course reflects in the quality measures, and that's great. We're also working with the patients on blood pressure and statin therapy as well, and being able to show your results and show that you're improving the quality measures is an added bonus to get more patients and more referrals into your program. So I'll just go into some details about the different roles of the providers on our team. So our team is PharmD led. We do work with the patients on medication management specifically. So that's kind of our swim lane for the pharmacist. When the patient comes in, we have them bring in all their medications. We go over every medication in detail. We explain to them why they have it, what their, the reason for the indication, the side effects, so that they're well aware of what they're taking and why. And this is for diabetes, blood pressure, and statin therapy, and any other medications that they might be taking as well. We talk to them about what's working, what's not, talk to them about side effects they may be having, and find ways to simplify the regimen that they're on. Maybe they need something better in terms of cost effectiveness. Maybe what the regimen they have currently isn't working for their lifestyle, and those can be barriers to good adherence. And so we try to tease out what might be happening in order to get something that's going to work for them. We do find that, patients are resistant to adding medications. That's always an issue. Also, the stigma of injections. We have a lot of great medications out there now, even that are not insulin, but still in injection form. So that can be a challenge. So it just takes a lot of time, talking to them. Sometimes there's some negotiation going on, but that's really when it's beneficial to have the other members of the team kind of help support that care plan that we're trying to make sure that the patient's getting the best for what would work for them. Our pharmacists do follow a loose protocol that we've developed. We review it annually, and it's based on the most up-to-date ADA guidelines. And in addition to the diabetes medications, blood pressure, and statin therapy, we're also addressing comorbidities that the patient might have. We make sure that they're getting their annual eye and foot exam screenings. We actually recently procured a retinal camera, so we can do the retinal screenings in the clinic now. And for any patients that need referrals, we'll help kind of triage that for them. And then we also make sure that they are following up with their PCP, that we're a collaborative program. We're not there to take over. We're there to work with the PCPs and any specialists that the patient might have. So the dietitian is a very important role on our team as well. We have 2 full-time dietitians. They're both CDEs, and they have extensive experience monitoring diabetes patients. And we hired them with that experience to begin with. We needed dietitians that could hit the ground running, that wouldn't require a lot of training, that had kind of done this before, and they knew what we were trying to accomplish. And the goal with our dietitians is really to work with the patient to create an individual modification plan. So you're kind of seeing the trend here. It's all about individualization, working with the patient. We place stress on modification, that we're not here to give them a short-term diet fix that's they're going to do for a little bit and everything's going to be great. It has to be something that's lifelong, that's sustainable in order to work in the long run. And then, as I had mentioned previously, we do reserve time for our dietitians to see the prediabetes patients, the patients with lower A1Cs, to provide one-on-one education so that these patients are understanding what they need to do to prevent progression. And last but not least is our social worker. Again, great benefit to have on the team. The social worker has a key role in that they're able to set aside, they kind of go in, they set aside, we're not going to talk about medication, we're not going to talk about diet, we're just going to talk about you and your life. And that's great. The patients really appreciate that. Like, finally, we're not talking about medication all the time or diet all the time. So they really focus on what are the motivational barriers, what are the social barriers, what are the financial barriers that are preventing the patient from getting to goal or where they need to be. Many of our patients have given up. They've been doing this for so long, they're just tired of it, and they're not really in a, maybe they haven't been in a place to listen. So our social worker really acts as a great health coach. They're calling the patient, they're encouraging the patient to take baby steps to accomplish the goals that we're trying to get better health for them. And help them move in the right direction, even if it's small steps. We don't want them to have giant goals that seem unattainable. We want them to move slowly. Our social worker will also perform depression screenings, and that's the PHQ-9, and that gets entered into the patient chart as well, so the PCP gets that information. And if the patient's exhibiting any signs or symptoms of depression, that will be an extra message to the PCP to let them know. That our social worker also has a protocol to refer our patients to behavioral health so that they can get additional treatment and therapy if needed. But our social worker will still really stay involved and make sure that they're following the patient through that process. Another great resource, or another great reason that the social worker is a great member of our team is because she can provide resources in the community. So we have caregivers of patients that are just getting burned out. We can give them resources for assistance. Some patients need resources for housing. Meals on Wheels, that's another great one that has really been just so beneficial for our patients. So really great member of the team to have. All right, so I'm just gonna finish up by talking about operations. We have 2 locations, our flagship locations in Fountain Valley. And last year we were able to expand and open a location in Irvine as well. That just helps with being more convenient for patients that live in that area. Our clinic operates from Monday through Friday from 9 to 5, and we are currently managing about 500 patients. We do allow about 1.5 hours for the new patient visit. That's because we have all those providers making all those interventions that I talked about, and it really does require that much time. And we let the patient know ahead of time so they know what they're getting themselves into. But we really haven't had much pushback once we get the patient into clinic and they realize how much time we're spending with them. The follow-up visits tend to be 30 minutes to an hour, about every 4 to 6 weeks, but it could be sooner depending on if we're making a medication change or if there's something we want to follow up on. And most of our visits are in clinic face-to-face. It's much easier for us to troubleshoot issues and just read body language and tease out problems that might be going on face-to-face. But we do also call patients as well. We understand that not everyone can take off work and come into clinic, so we try to kind of make that balance for whoever needs it. And we do put all of our notes into the EMR and communicate those to the physicians. We've also been known to pick up the phone and make a phone call if there's something more urgent we need to talk about as well. And then as far as graduation, our patients that maintain their A1C at goal for 12 months are graduated, but we let them know we're here for you. You're always welcome to come back if you feel like things are slipping or you need a refresher. So that's all I have. But now I'd like to introduce our physician champion, Dr. Coyne.
I wanted to start off with a couple of physician testimonials. Who can resist that? So, first is from me. I don't think I can stress enough how much more the PCPs value the care given to our diabetics by the pharmacists and active diabetes than by even the endocrinologists whose resources to track and educate our patients are just as limited as PCPs. There's better follow-up and better results. And from Peter Kim, the active diabetes program helps my most challenging patients reach their goals and makes it much easier to manage them. What PCPs lack, time to educate, convince, and micro-adjust therapies, the program provides with well-trained and outcomes-focused pharmacy staff. Patients love the results, and the ROI and satisfaction scores can't be beat. Highest recommendation. So I wanted to also give a couple of anecdotes just from my own patients, Kim. So first patient is Mr. M. He's currently a 38-year-old male diagnosed with diabetes in 1996. He had made me his primary physician in 2016, and I asked him during his first visit with me, so do you know how well controlled your diabetes really is? What's your A1C? Some people don't even know what an A1C is, but he positive. Finally said, I don't know, but I'm sure it was well controlled. So unfortunately, as is the case with a lot of these patients who have had insurance changes or lapses in insurance, their chronic health conditions often deteriorate. This initial A1C was 10.1%, not so well controlled. I enrolled him in active diabetes clinic immediately as he was a candidate. Unfortunately, he had a lot of barriers to care. He had obesity, he had erratic meal times, he checked his glucose infrequently. He often had very high carb meals, and on top of all that, he had financial difficulties, which made it hard for him to cope with some of his medications. But with the additional support from some of the cost-reducing programs and dietitians' frequent reminders and some long-acting insulin adjustments, his A1C improved to 6.8%. The second example is Mr. L. He's currently a 72-year-old male He was diagnosed with diabetes in 2008. He made me his primary physician in 2015, and he actually came prepared. During the first visit, he showed me his last A1C was 7.9%. Interestingly, he seemed insistent that a distant history of a gunshot wound to his head was the direct cause of his diabetes, since he couldn't exercise as much as he used to. Silently, I'm starting to think, is he actually creating excuses which might hamper his future compliance? But he had been actually treating his diabetes with a combination of short and long-acting insulin, but his levels would widely fluctuate. And so I sent him over to an endocrinologist, and fluctuations persisted. We enrolled him in active diabetes when an A1C rose up to 13.1%. So also hampering his treatment were his obesity, his non-compliance with diet and skipping meals, sometimes have a high-carb meal followed by a no-carb meal, and kind of punishment and reward type of system. I guess it was mine. But the non-compliance with medications due to financial difficulties and non-compliance maybe with his poor vision, which interfered with the correct insulin dosing, were big problems for him. But with intensive diabetes education, medication judgment, glucose fluctuations improved, and the A1C improved to 8.1%. Not everyone gets to exactly the goal, but I wanted to show these are the most tough cases here. And he had to reduce or even stop his short-acting insulin because it just was potentially too dangerous. Well, the diabetic patients we all have, they all have their own set of road bumps or potholes on the way to successfully managing their diabetes. And the typical patients at the active diabetes clinic often have many more social or financial barriers to adequate diabetes management. As was mentioned earlier, these often aren't the most severely, poorly controlled diabetics out there. It's critical to have a team which has an excellent fund of knowledge in not only the disease, but also the resources available to help the patient smooth out the road ahead of them. And without these resources, the team approach to diabetes would be far less successful. And we physicians often lack the time and training to adequately respond to many of these barriers, and patients often resist creating a structured diet and medication regimen necessary to success for various reasons. But when we fail as physicians at controlling our diabetic patients, we often rely on the ego-preserving assumption that it's patient compliance that's to blame, not our own lack of effort. I'll have to say that in the past, I had often relied on some of our local hospital-based and dietitian-directed diabetes clinics, oftentimes in the format of a group, for these newly diagnosed patients who often needed also additional instruction prior to starting insulin injections. But while these programs are helpful in the initial education, the problem with these is that a lot of times the education and the re-education were left up to the physicians during their less than frequent quarterly office visit, and the patient during those visits often had many other health issues to talk about, and diabetes took a backseat. So what the team at Active Diabetes Clinic was able to do is they immerse the patient in constant reinforcement and reminders and instruction in order to keep this mostly silent medical condition at the forefront of their mind. And I may joke to some patients that the constant reminders might sound like a nagging parent, but they really are necessary to make diabetes a part of their everyday life. And when the patients follow up with me, they are often enthusiastic about their newfound ability to have a direct and objective means of controlling their condition. And I'm almost hesitant to say it, but nowadays I refer all my eligible type 2 diabetics to Active Diabetes Clinic rather than the endocrinologist, where I know they'll receive better education and treatment and more hands-on care than either I or an endocrinologist could provide. So successfully implementing this program is really predicated on the immense effort on the part of the whole team approach, and I have to say, yes, successful with that combination of really strong, engaged PharmDs, dietitians, the social workers. Its success is also dependent upon the physician support of the program. As Kristi was mentioning, some physicians might be a little hesitant about saying to patients to this type of thing, but every time that I or any other physician sees an active diabetes patient during office visit, we need to validate with the patient that the expertise at the Active Diabetes Clinic is excellent, and we encourage the patient to follow through with the recommendations. So now I'm going to turn it back to Andrea for the return of investment discussion.
that's what you feel. Now I'm just trying to focus on the later years of my life and my health, and don't think I'll ever put the brush down again. It helps me stay within myself where I can think about my health and not everything else going on. I had cancer 20 years ago. They told me I'd more likely to get diabetes. My mom had it, and sister. It was hereditary, and I'm probably going to get it. When you do face it, a lot of times it's too late, and you have to do everything you can to beat it. My mother wasn't so lucky. She was a diabetic for a lot of years and cut her life short.
Greater Newport Physicians' active diabetes program is very unique. With Joe, his diabetes was getting to a point where it was difficult to manage. He needed much more attention. And I referred Joe to the program to help co-manage his diabetes.
When Mr. Riddle first came to our program, he was really struggling to not only control his diabetes, but he was also struggling with his diet and lifestyle, and it was even affecting his quality of life.
Any doctor that calls me like she has over the times that weren't always so good is pretty incredible. She communicates with Dr. Weichel, and between the two of them, keep me going. No matter who it is in that building, I treat it like a king. People that work there don't take it as a job, they take it as a passion, and they take it as fixing people, caring for people.
Diabetes, and like anything else, is not a one-size-fits-all. We get to collaborate and brainstorm with each other to have the most effective treatment plan for that member.
Since Joe started with the Greater Newport Active Diabetes Program, his blood sugar control has improved significantly, and he's been able to maintain that.
And I just don't give up. From where I was a few years ago to where I am now, I'm able to be much more active. I don't have to worry about everything like I did. I just can't say enough about it. It's a great program. I wish everybody could do it.
We are always looking to provide better care. Most of us went into medicine because we want to help people. And one of the things that really makes that special at the end of the day is when you feel that gratitude back from the patient, that he looks me in the eye and he shakes my hand and he thanks me.
I want to be around for my 3 sons to enjoy my 6 beautiful grandchildren. I definitely want to be around. This great program, you have people helping you, supporting you. They really care.
They left that up to me, and it didn't go as smoothly as when he does it. So I agree. I wish everybody could do it, but I'm going to say everyone can do it. And our goal of sharing this program with you today is to hopefully plant a seed and allow you to realize that you can do the exact same thing that we've done. And I will tell you that we will leave our contact information, and if you need support or you have questions after the meeting, starting something like this, that we're all in with you. We presented at a couple of Hattie's meetings, and there's one organization that actually has reached out to us, and they've done a site visit a couple of different times, and I was hoping they had started so I could report back to you today that they were successful, because, you know, it's great that we did it in our little part of the world, but it'd be even better, and I'm sure Hattie would love it if we could spread it across the state of California. So here's partly how you do it. So you have to have an ROI. You don't need grant money because you will save. You'll be able to fund the program with the medical expenses that you save in this patient population. And so the reason we know that is because, one, the grant money ran out. So back up a step. When we started the program, we were affiliated with another hospital system. Fast forward a few years, now we're affiliated with a new hospital system. They're not familiar with anything that we do. And the grant money was running out. And so I did reach out to Blue Shield, and I asked for enough money to get us through the fiscal year, and was quickly working on an ROI